Thank you for inviting me for this conference, especially from the nursing side. And for next 15 to 20 minutes, I would speak on ethical framework for decision making in pediatric end of life care. As Madam just started saying that we are all mortals. We are adults or children. Uh, we are all mortals, and with unfortunately, some people's life gets shortened due to an dreaded illness like cancer. And when we are dealing in those situations and settings, we need to make decisions for the children and for the family. And the best way to make those decisions is to have an ethical framework. We always talk in terms of legal, and whether it is legal or not. And less often we talk in terms of whether it's ethical or not. The highest level of decision making is to know whether it's moral or not. So we have like three layers: moral, ethical, and legal. Legal is the least minimum, what we say. So I'm not talking about moral or legal. Now we are talking about the middle part. What is ethical thing, and what is the ethical framework that you should use for decision making in pediatric end of life care? So if you see my presentation, I would talk about situations where goals of care change. What are the various choice of goals of care that we have? How to plan goals of care for the patient and do an advanced care plan? What are the decision making and communication that we need to do while we plan goals of care? And the last bit is what is the overall ethics that is involved in the pediatric palliative care practice. Now, unfortunately, within the treatment trajectory or the illness trajectory, there is this transitions, what we say. That means a diagnosis has happened. With the diagnosis, the illness has progressed or spread, or the disease has come back, or there is a complication because of the illness, or there are side effects of treatment, or there are difficult to control symptoms, or child or the parent or the families have some personal choices, or you are making decisions based upon certain contextual situation within the limitations with which you work. So all these situations are what we call as the turning points, where the goal of the care keeps on changing. So we need to be equipped in this situation as to how to make decisions and how to plan treatment for the patients. And what would be our normal choice of goals of care? Now, if you ask everybody, what do they want? They want a complete cure, isn't it? The child wants a complete cure, the parent wants a complete cure for the child. Sometimes this is not always possible, although in pediatric malignancies, if they get an excellent treatment, 80% of the children, 80 to 90% of them are curable. But that's a very ideal, optimistic situation, which is not always happening. And sometimes cure is not possible, then at least prolongation of life or control of the illness is possible. Avoidance of premature death is possible. Sometimes both may not be possible, and the only thing that is possible probably is to give them a relief from the pain and symptoms and to improve their quality of life and make sure that the child does not suffer during end of life, and the parents are well supported during that period of time. So there are various goals, and these goals are not like set in stone, or it's not that they are very unidimensional or only one goal apply. Multiple goals apply together. There may be a child who says that I want to be completely cured, but at the same time I want to be completely free of pain. Perfect. That's the best thing that we could do. And sometimes these things could change. You may have a family who may initially decide that, okay, I understand that my child has a very progressive cancer, and we would do only those things to improve quality of life. But next day or sometime later, they may say, no, we want to try this new chemotherapy drug or the new treatment that is available. So this things keeps fluctuating, and sometimes they may be even in a conflicting or contradictory manner, that they want a very very aggressive chemotherapy, which could cause a lot of suffering, many days in the hospital stay, or a lot of side effects. But at the same time, they want a good quality of life, good symptoms. And we could try to accommodate everything, but sometimes it may be very challenging to do both of them. And one goal could take a precedence over another goal. So we need to understand all these things as we plan goals of care. So as I said, these goals of care keep shifting across the trajectory of illness. So along the trajectory of illness, it keeps shifting. So initially, the primary goal would be curative. That means the mindset is to eradicate the disease. Even if there is a major side effects, we are accepting those side effects. Your attitude is to win always, and you, if there is a need for CPR, it's yes, and symptom control comes very secondary here. The primary aim is to eradicate, and major side effects are acceptable. It could change from the curative to a life prolonging palliative, where the impact of the disease is to arrest progression or control. Previously, it was cure. I always use the 3C analog: cure, control, comfort. And the second C, that is what we're talking in terms of control. Some adverse effects definitely are acceptable. So it was win before, psychological attitude. Now it has become fight. And preference to CPR, yes, no. And symptom relief, yes, it comes into. And as it changes, that's the third C, that's a comfort, where the goal is mainly symptomatic treatment or palliative. So your main thing is to avoid complication here. Adverse effects, probably you are not going to take any treatments, it's minor. And psychological attitude probably has changed from win, fight to more of an accept. And probably these children are not suitable for a CPR or a prolonged ICU stay, because they have a far advanced disease, and then these things may not help. So you see how these goals of care has shifted from one to another. So when we talk about a comprehensive care plan for the patient, we always have to look more broader. We are trained as doctors to look at medical treatment planning. So there is a disease management goal. But even within that, you need to look at, when you are making this care planning, this whole care planning is an ethical framework. So when you make this care plan for the patient, there are six parts to this. So one is the disease management, symptom management, communication, decision making, practical, and anticipatory. All of them are ethics based planning. So when we look at disease management, you look at what is the benefit of the treatment versus the burden of the treatment. Now, when you are starting a new treatment or stopping something or changing something, always look at ethical side. What is the benefit it would lead to? What could be the harm? Does the benefit clearly outweigh the harm? So that helps you to make an appropriate treatment decision making. So that is the disease management goal. The second part of the care plan is the symptom management goal. So along the treatment, you need to ensure that the patient's pain and physical symptom, their emotional needs are met. If the pain and physical symptoms are not, our needs are not met, the emotional needs are not met, it's not a very ethical treatment. We are just doing what we have to do, but it's not helping them, because their quality of life will be significantly reduced. The third part is the communication goes. How much the child and the parent knows, what do they like to know, and what does it mean knowing to them. So lot of time this information about diagnosis and prognosis are not provided, or they are very ill informed. They may vaguely know about some diagnosis but not knowing about the prognosis. So it's a very important aspect. The fourth part is the decision making goes. Who makes the decision? How much is child empowered to participate in this decision making process? Is someone else making the decision? Are they making those decisions in the best interest of the patient? All those things are ethical questions that we need to ask. Practical goals. Where would the child like to be treated? Is hospital is the place they would like to be treated? Is it at home? Is there somewhere else? If they have to go from hospital to home, what kind of setup they have at home? Will they be able to care for that child at home? Do they have the logistic support there? That's a very important aspect that we need to think. And the last part is anticipatory growth. Anticipatory growth is to look ahead into the future and look ahead and see, okay, what could happen and what do we need to plan. Now, if you have a child with a far advanced disease at some point of time in the future, child could have a compromised cardiopulmonary function. That means the heart could stop, the lungs could stop, and probably they would rush to an ICU and they'll put on a ventilator and things like that. Is that the right thing for the child? Will those things help? What would be the preferences of the parents, and if possible a child who could participate in the decision making. Now all these things are ethics of decision making. So you have the six parts: the disease management, the symptom management, communication, decision making, practical, and anticipatory goal. Only if you could address all the six dimensions, then only your care planning is ethical care planning. So we need to understand, when we make a decision making, it's always a shared decision making. Normally, what happens, the decision making is very paternalistic or father like. I know what is best for you, you do what I say, isn't it? That's very paternalistic. An ideal decision making is shared decision making, where the medical practitioner, the doctors, nurses, healthcare providers come up with their medical knowledge, expertise, etc. And the family would come with their wishes and preferences. You meet somewhere in the midway and try to get a solution which is acceptable for both, isn't it? So, most important thing is to know that they're ready to discuss this. You could elicit those goals. You should make recommendation, establish a plan, and always document it. A lot of time what happens is this decision making process is never done. So when there's no decision making process, our decisions are all temporarily made. That means they are made at that point of time without looking at the overall picture. So it becomes a very reflexive action rather than a very planned, deliberated action. So always we need to understand, in a given patient, we need to be very reflective and think that what is reasonable for the patient and family to hope for in this given situation. What is that they could hope for? What is the realistic goal that we could achieve? And should you set limits? Because family could go on demanding one thing over another thing, but will it help? And should you set some limit? Is there a coherence between what we call trajectory of goals and trajectory of illness? So, what do you mean by trajectory of goals and trajectory of illness? So the cancer is progressing in a certain path or in a curve, but the cancer is somewhere else with its extent of the disease, but families' hopes and expectations are somewhere else. This is not matching. You may clearly think, okay, this patient has got a metastatic cancer, refractory to all therapies. Probably there are not many options remaining. That is the trajectory of illness. Whereas the parents may be thinking, okay, the child has received chemotherapy and child could receive more chemotherapy and child could get better. So that coherence is missing. Also, medical versus non-medical goods. We are only looking at medical goods. We doctors are trained to think like disease-free interval or progression-free interval. These are all medical goals. What does the child want? What does the family want? What are they hoping for? What are they aspiring for? That is a non-medical goals. That's very important. And is there consistency of goals between patient and families? Because families might want something else, whereas a child or an adolescent who is receiving the treatment want something completely different. So then there is no consistency between them. And sometimes what happens is these families may not be ready to discuss the goals of care. And also a lot of the problem comes from the healthcare providers. They do not want to tell the truth because they feel that they will dash the hopes of the families. They do not want to address the benefit versus burden, or they do not want to discuss the meaning of doing an intervention or not doing. What does it mean for the child? And also, the last point is very important, is whether you are able to continue treatment without abandoning. Because a lot of times I get to hear from the parents is that my doctor has told that don't come back here because there is no further treatment they're offering. That they perceive it as abandoning, because if you do not have a treatment, that's fine, but that bond that has been formed between oncologists or the cancer hospital or the cancer nurses and the child and the family is a very strong bond which cannot be broken on a one day. So we need to probably have a very slow transition process, whereas one service becomes less and less relevant and the other service is taking more and more. So that's very important. And again, how you communicate is also important. Like, will you agree to discontinue care? That's a very negative statement. We will focus on comfort and improving quality of life. A lot of times, people ask me, or the families, doctor, you will do everything possible for the patient. No. So I always say that, yes, we will do everything possible for the patient that's going to help the patient. So you're not telling that you'll not do everything possible, but you're going to do everything possible that's going to help the patient or help them to live with their illness as long as possible. So the language of communication, the way we communicate, the way we talk is very important. So what are the steps in communicating goals of care? Is to create the right setting, find out what the patient and family knows, how much they want to know, and what are they expecting or hoping for. So before you talk anything, always find out is what they actually know, what do they know, how much they want to know, and what are they expecting to know, isn't it? And then set realistic goals. There are a lot of emotions when you communicate. You need to respond it very compassionately and make a plan. So there are a lot of this communication is an ethical need to communicate well. So when we communicate, the way we communicate is very important. So there are what we call as the 8 steps of communication when the goals of care are changing. The first step has to talk about stopping a disease modifying treatment. So always when we are deciding to stop something, we need to appraise of them at the current situation, recapping them, explaining why we are making this decision in terms of the illness becoming refractory to further treatment. The burden is clearly overweighing the benefit. And do not stop there. Always provide an alternative and always provide what could be done apart from that. The second thing, as I said, is transition of care. I mentioned how there is a bond that is being formed between the cancer providers and the child and the family. So, to avoid abandonment or to avoid distress to the families, we need to have a very uh, a slow transition. So that's why we advocate for early palliative care, where palliative care providers are involved earlier. So they are familiar with the patients, and the patients and families are familiar with the palliative care providers. And this slow transition. So initially, there will be a period of a time where we call it as shared care, where both of the providers are providing care for the patients. The third part is prognostication. Often families would like to know what's how much the child is going to, how much long the child has got, or what's going to happen for the child. So again, very sensitively communicating it is very important. And the other thing, the parents are very worried, or even the child is worried about is what's going to happen in the future. So a lot of them are very apprehensive. Am I going to die with pain? Am I going to choke and die? Or am I going to have breathlessness and die? Or am I going to suffer and die? So there's a lot of this fears are there which you need to address. And you need to give a very realistic reassurance. And when they ask that question, they do not want an yes or no answer. People say that no, 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 don't worry, nothing is going to happen. That's not the answer what they're expecting. The answer what they expect is that whatever that happens, we are going to be around to make sure that you don't suffer or you don't have pain. That is the realistic reassurance what they expect. And as I mentioned, that we need to have a system for an advanced care plan to look at and see that if things change in the future, how we are going to manage this child. What should be the place of care? What are the systems that we need to put in that place to care for the child? What could be our medical goals for this child and non-medical goals? So this is an important part of planning. And the important decision that we need to make is about the life sustaining treatment. In terms of that, if we reach that point of time where heart and lung needs to be supported artificially, would is that something they would want for their child? Or if the child is able to participate in the decision, is that something the child wants? And and most of the time, when you clearly explain to them that fertility, that means continuing this therapy, has got no benefit. Okay. So then, usually, most of the families do not want their loved ones to suffer much more than what they would suffer. So it's very important to bring these points also while discussion. And there would be also certain specific situations on which we have to deal with. Especially, there will be a situation on denial. Families may be in a denial state that the child has the disease has come back, or there is not going to be any treatment. A lot of time we face the situation of collusion where the child is kept in dark and the doctors and parents are continuously communicating without involving the child, or an adolescent uh, where they are completely out of that. There could be a very conflict situation in terms of mother and father having a disagreement with a line of management or an unrealistic expectation. All these things we need to have a good communication to manage them. And also in the terminal phase, to look at what to expect, because when the child is dying, they're in a very state of heightened emotion, isn't it? So what to expect? What does this each symptom mean? Because if there's some gurgling sound that's coming, and family may think that the child is in enormous distress. So you need to understand what is the meaning of this symptom, and the communication that needs to happen. So these are the some parts of communication. And there are a lot of challenges to discuss goals of care. Most of the things comes from the healthcare providers. They don't want to discuss expectations. They don't want to broach this topic or talk about it. Sometimes we are always good at offering interventions. Okay, this is not possible. Why don't we try this? Because we want to avoid this question. We always want to give something. uh, you may offer a new immunotherapy or a new modality of treatment, but not addressing the elephant in the room or the problem. And always the language with unintended consequences, stating that don't worry, everything will be all right. That's a language with an unintended, your intention may be very good, but they will be worried and everything is not going to be all right. So the language what we use, offering a false sense of hope here, and excessively optimistic estimates of prognosis. So there's some of the challenges that we see. And also from the healthcare providers, maybe a doctor or nurse, they feel that sense of helplessness when they come to talk. They have to talk about it because they are all of us are trained to cure something or fix something, and when we are not able to cure or fix something, we feel that sense of helplessness, and it's our own fears of processing death and dying. Maybe we don't have time to discuss, maybe we don't want to deal with the emotions or the anger of the family when we bring about this thing, or we may constantly feel that we should do reassure everything and make it right, or we may fear of destroying hope. So all these things are some of the challenges that exist. Now, coming to the last part of my presentation, what are the core ethics that what we see in pediatric palliative care practice? So, whenever we make any ethics-based decision making, it is what we call as the triad of decision making. So, you have the child, you have the physician slash healthcare provider, and the patient and surrogate. Now, the physician or the any healthcare provider should act in the best interest of the child. Anything treatment that is offered should be beneficial for the child. It should not cause harm, and every attempt should be taken to avoid harm. And the resources that are there, what we call distributive justice, has to be fairly allocated. So, this is one side of the triangle. The other side of the triangle is the child. The child is informed and assents to the treatment. The child is empowered to participate, and the child could voice the wishes. The third part or is the parent or the guardian of the child. They have an informed permission. Okay, so it's an informed assent from the child, informed permission. The autonomy is a shared autonomy. So we do not talk in terms of absolute autonomy. So as I written, a poor model is the doctor only making decision or the parent only making decision, where the child does not have an autonomy. Here the shared autonomy is always shared with the child, and it's called as a substitute judgment. That means the parents, when they are making decision, are making decision because the child does not have the capacity to make the decision. So they are making decision in the best interest of the child. So that's why it's called as a substitute decision making or substitute judgment. So we always do not talk in terms of decision making capacity in terms of competence. We talk in terms of decision making capacity. Competence is a more of a legal term. We look at the decision making capacity, whether they have the necessary cognitive and developmental skills to make an informed decision. It does not mean that they are 17 and a half years, but they cannot make decision because the law says it's 18 years. They may have all the cognitive and the developmental skills to participate in this discussion and make decision. So it's very important to look there. The second thing is that it is not an all or none phenomenon. In legal, it is all or none. When you're above 18, you are fully mature and you can go vote, you can get married, and it's all or none. Whereas the decision making capacity is very graded according to the cognitive development and the developmental milestones of the child. It is very graded. So decision making capacity is a more medical than the legal part, which we talk in terms of competence. And also the decision making, we look at what is called as the margins of life. In a neonatal setting, we look at the beginning of life. So we get a lot of patients referred from neonatal ICU with uh, the immature, the child prematurity with hypoxic brain damages, and there's a lot of prenatal and perinatal palliative care that what we look at. This is the beginning of life. The end of life is the child who having a far advanced disease, a far advanced cancer, who is dying, where there are a lot of ethical consideration, especially looking at the fertility, of the child, and these are very uncertain things. Whereas beginning of life is much more uncertain compared to that of the end of the life situation. So this is what we call it as the framework for ethics-based decision making. So we look at the four aspects: the medical, the wishes of the child and the family, quality of life, and context. So medical, as we have mentioned, any treatment that should have benefit and less harm. So benefit should clearly outweigh the harm. We should always look at what's the diagnosis, what is the prognosis, what is the reversibility of the illness, what is the success of treatment, what is the goal of your treatment, intention of your treatment, what alternate that we can provide. From the wishes perspective, what are the child's wishes, parents' wishes? Is the child able to voice the wishes, and are those respected? From the quality of life, we look at what are the long-term benefits in terms of quality of life, what are the long-term deficits,
We are overshooting
what
the
is the rationale of our decision making, and lastly, we look at the context on which the decision is made. So I know I have exceeded probably the time. Um, so I'll just come to the last part of my talk is to look at situations to limit treatment. So these are the four things that what we bring in, what is called as a no meaningful life situation, like a permanent vegetative state or no chance situation, when there is an expectation of imminent death despite aggressive treatment, no purpose situation, where there's a significant decrease in quality of life, and an unbearable situation where there is significant symptoms that is affecting me. And thank you so much for the opportunity